Hi, I'm Rob Brandis. Tonight I plan on sharing with you some of my 30 years plus of dental experience in the profession and 15-year plus experience in cone beam, as well as educating cone beam with general dentists over the past 12 years. I appreciate your spending some time with us, and I think it's the commitment to continuing education that really keeps our profession on top. So let's get started. There's a quiet revolution going on underneath our feet over the last 20 plus years that's technology based. This revolution is happening quietly in a way that we don't often even notice it. When's the last time that you used a dictionary, for example? A lot of you may not even own a dictionary any longer. When was it the last time that you used a phone book? Do we even have phone books anymore? They're hard to find. Those things became antiquated right under our feet, and we changed to a better technological way for doing that. When's the last time that we used a map or used a map when we were driving? There again, some people, but not very many. Whether we like it or not, this quiet revolution is happening underneath us, and it's changing our lives, and it's doing the same thing in dental practice and has been for some time. Sometimes we have small jumps in technology, other times we have large quantum leaps in technology, and sometimes we're trying to catch up to the technology that's out there and figuring out what to embrace and how to use it. When it comes to cameras, this is an example of a 2D camera. With a 2D camera, we take a picture of a real object and we see a flat representation of that. Today, there's 3D cameras, like the one represented here, that can take multiple pictures of a real object, and then with computer software, transmit that into a three-dimensional object. And we can see all kinds of things in 3D that we could not see in 2D, where 2D just comes up short. And this is just a small list of those things. So there's a couple of burning questions that I hear all the time when teaching cone beam. And if you haven't got into cone beam yet, I understand. It seems like a short time ago, but it's actually 15 years ago for me that I started down the cone beam path. And the burning question for me, really first and foremost, was, do I really need this? Can I get by just fine? Everything seems working okay in my practice. Do I need to have it? And then, of course, if I have a really same kind of question related, what's the benefit to having cone beam technology? And most importantly, with the cost considerations, can I get a reasonable return on my investment, at least pay for it? And of course, if I'm going to do that, where do I go for it? Well, there's questions, even if you're using cone beam technology, and I certainly intend to address those, because during this presentation, I plan on not only providing information for dentists, but for back office people, for hygienists and assistants as far as how to use cone beam, and even front office people, how to collect those images for third party, for example. And so you need some familiarity with cone beam and to understand it, and to be able to field questions from patients. And then I even have some information I think is going to be helpful to the dental manufacturing and sales staffs, where we can get a lot of information about what the potential for this technology is, because I think a lot of it has not been represented as well as it could be. So if you're already using cone beam, what might some questions be that center around that? And here, am I maximizing the use of the cone beam in practice the way that I should be? Does it have a lot more potential that I haven't tapped into? How can I make that work with my workflow? And really, can I do a better job with showing off this technology to patients so that it can help drive improved case acceptance? Really, what is cone beam technology? Let's back up for a second and notice that I used Wikipedia to get this information, not a picture from the dictionary or a copy of the dictionary. And really, cone beam very simply is a scan, very much like a panoramic scan, scans around the patient's head, makes a 10 to 15 second pass depending upon who the machine is made by. And it takes literally hundreds of pictures. Then highly sophisticated software can refigure that images and stitch them together and create what we call voxels. Voxels are just squares, little tiny squares of digital information. A flat 2D picture would be a pixel, but a voxel is a three-dimensional thing. It's a cube, and then it can take these cubes and put them all together and make what we call a digital volume. So here's that cone beam going around the patient's head, that max kind of 15-second scan that they just need to be still for. The main problem with that, obtaining a good scan, is getting the patient positioned best and not having them swallow. So very simply, we're kind of familiar with that. We're kind of familiar with what the machine looks like if you're familiar with the panoramic X-ray machine, very similar. In our discussions tonight, I want you to set some goals for yourself so you can get the maximum out of this. Make sure that you really kind of drop into this and try and learn what its potential is. The learning curve for cone beam is very quick to learn how to navigate and understand its potentials. And it's not difficult at all, even if you're not tech savvy, to really change your world by embracing this technology. Because one of the other quiet secrets or quiet revolutions is this, I believe, cone beam is the greatest instrument that's ever been invented for dental care. It's transformative. It changes my practice and practice decision-making every day. So again, to go over a couple of the goals for the evening, understanding 3D every day is a big part of it, because if you're utilizing it the way that I believe it should be used, you can use it all the time, and every patient can benefit from cone beam. I'm going to talk about that extensively and what it would look like, and show you lots of examples of what it would look like if you're using this every day in 3D practice. I want to talk a couple minutes about navigation and how to get around and the things you need to learn how to do. I want to talk extensively about the diagnostic potential of the technology and what you can do with it to show patients what's going on in their mouth, and how, if they have some experience in seeing these images in your office, oftentimes you can do code discovery. Patients will engage these images. I'm going to spend just a brief time talking about endo. It has lots of potential in endodontic therapy. And of course, implantology, the big push that cone beam's been made with manufacturers has all been made in implantology. Fantastic machine for implantology, really changes the field of implantology. And although I think that manufacturers haven't understood all of the other capabilities besides just the implantology. And then of course, if it can't pay for itself, it doesn't make sense. But we're business people, and we need to make sure that what we do is financially responsible. So I'm going to talk a bit about that too. So answer this question for me, please. What do you see as the greatest benefit of having cone beam in your office? Is it diagnosis, implantology, endo, or a case presentation to patients? And I think it certainly has value in all four of those things, but what do you think the greatest potential is in? And I'll put my ear up to the screen, although I can't really hear anybody, but by far, I think, having lots of experience in this, the greatest potential is in diagnosis. As good as it is at those other things, the increase in diagnosis is fantastic. And so I'm going to show you exactly what that looks like. But dropping back, let's take a look at what the problem is with 2D x-rays. And we certainly are very familiar with these. We all in the dental profession have some experience and education with regular two-dimensional x-rays. Well, the main thing is you have distortion. We don't have the ability to measure things. And obviously, we're looking at a two-dimensional picture of a three-dimensional thing. As we're looking at this periapical image up here, we can't see what's behind this. We don't know what's in front of it. We don't have any orientation. We can't tell whether it's shorter than this or longer than this. It's all based on where the x-ray head is located versus where the sensor or the film is. We have variable distortion. That variable distortion is something we work with all the time. If you look at this image down here on the bottom, we see this panoramic image. This is if the panorama was made into a photograph, and you can see how much everything is stretched out here, stretched out. We're used to looking at this image and we understand that. We actually get double imaging and overlapping of images, as you see back here in the ear. And the magnification in this area may not be the same as the magnification in this other area. So there's variable distortion. It's useful, but it's not as useful as it could be. So What does it miss? Well, it misses undercuts. It misses this kind of anatomy that you can see in a cross-sectional view of a cone beam right here, where we're looking at things really from the side. We can see the shape of ridges. We can see the narrower wideness of ridges. We can see empty spaces. And we can see the orientation of the upper arch to the lower arch. We can see how those relate to each other. None of those characteristics can we see, for example, in a traditional pan, even if it's the high quality digital pan. So what about 3D? Well, 3D, we have the ability to do true measurement, true image. We can take an image, we can make it larger, we can zoom in on it, we can measure it, and we can know that that's the exact measurement. Why? Because everything in cone beam is a 1-to-1 ratio. There's no distortion. If you make it bigger, might as well make it bigger to see it better and explain things to the patient, but we also can measure more accurately that way. We can see all these anatomical irregularities, and what do I mean by that? Well, look at this side on the mandible right here, and we see a huge undercut here. And on the same patient, on the other side, we see no undercut. So there's huge anatomical variation from patient to patient. Look at the ridge on the maxilla on this side versus the ridge on the maxilla on this side. So being able to measure all these things and not having everything superimposed like it is in 2D is a problem. We talked about the axis of orientation. We can see the relationship of the upper and lower arch. And that allows us, all that additional information not only allows us to see a lot more in depth, but allows us to do planning regarding placement of implants, for example, and knowing exactly whether there's enough room for that. It allows us to map root canals and canal pathways and other things, all in a 1-to-1 ratio and not have any distortion. So we can see everything from every angle because we can decide how to slice through this volume in ways that become useful to us. So what's changed? Well, if you look at this technology, this quiet revolution that's going on, boy, this happened right under our feet. It took a long time here for us to get from the phone on the left to the middle phone, which now sort of looks like a walkie-talkie, but that's a mobile phone. That was a big improvement. We weren't attached to a cord by everything we wanted to do. But then we made a quantum leap to the phone on the right. The phone on the right, the smartphone, was a phone that really has revolutionized the technology. This quiet revolution happened, and that's where we made one of those quantum leaps, not just a better version of the same thing. I'd contend that the phone on the left and the phone on the right both don't function that much different as phones, other than you have portability on the right. The phone on the left probably has almost as good a sound as the phone on the right. However, obviously the one on the right has all kinds of other capabilities. The genius of the product on the right, by the way, isn't, in my mind, all the things it can do, which we all know is pretty darn incredible, but it's how it can do it in a very user-friendly way. Have you seen a manual about how to use any of the apps on your phone? Have you read that? If you are, you're really into it. But we can use all these functions because the software is very user-friendly. And the best software in cone beam is also very user-friendly. So looking at this evolving technology, if we go back to the left here, film was the standard in dentistry for 150 years. It gave us lots of information that we could not see, visually in the mouth, especially as far as cavities and other things. But we got a lot of information from that. This is a Perio Pro. This was my first venture into dentistry. It was the workhorse of the practice. In imaging, it always had notes on this about when to change the developer or the fixer. And we got by with that for quite a long time. Still, it's two-dimensional imaging of a three-dimensional situation, so it has limitations. We improved to that when we got to the middle, and the middle certainly was an improvement. Digital x-rays with sensors. We could get an image really quickly without film, without fixer and developer. We could make it happen pretty quickly. It came up almost instantaneously, but we still have the same problem with the image. We don't have any true measurements here, and we're looking at a two-dimensional picture of a three-dimensional thing. It was a big improvement, but it wasn't until we got into cone beam that we made the quantum leap to really reconstructed three-dimensional images. As we got more information, we were able to get the treatment on target and do better for the patient. And today, as we get clearer and clearer information, this high level of information that's contained in cone beam allows us to get our treatment and our diagnostic capabilities on track. More information, not only better diagnostics, but better decision-making about what the treatment should be. And we have the ability to get things right on target, not miss from time to time. So let's talk about how we slice through this volume. We have this three-dimensional volume of all these little boxes, these voxels. And if anybody's familiar with the TV show Dexter, what did Dexter do? Dexter sliced people up, right? He looked for the hidden secrets right beneath the surface, and that's really what cone beam does too. So in order to better display this, we've created this animated version of Dexter so that you can sort of understand how things work. I find in teaching cone beam that a lot of people that have exposure to this don't use the slicing features of the technology in the most advantageous way from a dental standpoint. What does that mean? There's a couple different primary ways to look at it. So let's take a look at the first one. Now imagine that we have three knives, and these knives can slice through this on any plane that we want to. So one knife would slice from the top of the head down to the neck. The other one would slice from the front of the face all the way to the back of the head. And the last one would slice from ear to ear in that plane. So let's take a look at what this looks like in the recreated Dexter. So here's that top to bottom knife. We're going from top to bottom, going through the scan. Look at all the hundreds of images that we would see if we stopped anywhere along the way of what we can see. We can also slice from the front to the back. Notice these slices, these knives work independently. We come forward, again, looking at hundreds of images. And we can also do that side to side or ear to ear, kind of from the side. All those work independently. And this is called the radiology or MPR view. The MPR stands for multiplanar reconstruction, but this primarily is used in radiology, pathology. This is where the biggest use is. A lot of people I see that don't have experience with cone beam will be looking in this image for what they want, and it's not the most efficient or dentally useful version of splicing technology. And really to understand how to use this every day, we need to look at this in a better way. Let's take a look at this, what it would look like in the scan. Now, if we look at this box on the upper left here, we're looking at the axial view. That is from the top here all the way down through the bottom. And if we look at the next view, that's this one here in the lower left where the dark bar is, we're going through the coronal view. That's from the back of the head all the way up here to the front of the head and the front teeth, the nose, the lips, all the way back again. That's the coronal view. And then the last view is this oblique view. That's from side to side. That's almost like the head is turned sideways. Notice we're looking literally at hundreds of images as we go through this. We can move back and forth. We can move as fast or as slow as we like. We can focus in on an area. That's the MPR radiology view. Now, can we make this much more dentally useful? And the answer is yes. And that's what Dexter 2 represents. Now here, all of those little slicing knives are all hooked together. They're hooked on the axial plane. And our focus here is on the dental arch, on the teeth themselves as the teeth go around. And they represent the curvature of the upper and lower jaw. And the things we want to cut through are in that curvature, what we call the focal trough. And that way we have a way to look at this in a much more dentally useful way. Now let's take a look at what that looks like on Dexter. So here we see the trough, the axial view. The white line is the axial view. We're going up and down. And now as we start to go distally here, the yellow view is the cross-sectional view. And the blue view here in and out is a buccolingual view. That's the tangential view. We're coming back again cross-sectionally here. We're coming out. And you can see how we're looking at literally hundreds of slices here, back and forth. We can move this in any way that we want to. And that's what Dexter can do, going distally here. And then back out to the cheek. So what does that do for us? What does this image of Dexter do for us and understanding this view? This view is called the panoramic or multi-window view. And it's important that we wrap our brain around this because this explains why we see what is going on in this multi-window view. With a multi-window view, we can see all kinds of things. And we look at something, we look at it in a dentally useful way. We can look at it from a coronal or crown length all the way down to the apex. That would be the axial view, back and forth of a tooth. We can look at it from a mesial distal direction, that's from the side, that's the cross-sectional view, or we can look at it in a tangential view, and that is from the buccal to the lingual. And those are things that we all understand, and now we can make it very dentally useful. Now let's take a look at what this looks like on a scan. So first the axial, there's that representation of the trough. We're going up and down. Here we're going up and through the arch, now through the upper arch, all the way to the top of the head. Now we're coming down again. See, we're seeing hundreds of images here. Now we're looking at the middle box, that's the red outline box here, and that is the cross-sectional view. So we're looking at everything from the side. As we scan back and forth, we're looking at literally hundreds of images. And so we have a good representation of every kind of view that we'd like to see. And here again from the side, mesial distal, that is the cross-sectional view. The next view we're going to look at is a tangential view. That's simple to understand. That's from the cheek side to the tongue side. And again, we can focus in on the area we'd like to look at, an individual tooth. We can scan from the cheek side to the tongue side to the cheek side, go back and forth as many times as we want, move as fast or as quickly or slowly as we'd like to. And this is where we want to be. The panorama or multi-window view, that makes things completely useful and understandable to the dental profession. Again, remember the MPR, the multiplanar reconstruction, the radiology view is a square, everything is independent and moves back and forth through the entire volume, looking at all the structures contained within that volume. And the panorama view focuses in on the upper and lower arch, the teeth, in other words, and allows us to move in a dentally useful way. Mesial, distal, buccal, lingual, apical, coronal. So what are the basics? What are the basics you need to know if you're just working in the back office, for example? Well, even if you're not really studying these images, your staff member, you need to know how to open a case. You need to determine how and which is the active window. It's important that you learn how to zoom in and drag and scan through volumes. And when necessary for patients, we want to make things full screen if we're doing demonstration. So those simple basic tasks are something you should challenge yourself to do, to really implement if you don't completely understand that. The great thing about cone beam learning curve is very quick, and going to the deep end and jumping in is not a problem. You'll once you spend some time with it, with a few little tips, you'll really be onto it right away. What does the front desk need to do? They need to learn how to collect images from this sent by the back, print them out, and be able to use them for third party when necessary. So if we do this all the time and we're using this as part of our exam, let's say a cone beam scan plus 4 bite wings instead of a pan, what are we going to see? And I've got a series of cases here I'd like to show you. Now, this type of apical lesion on tooth number 14 would be detectable with film. It would be detectable with a digital sensor. We'd be able to see this in almost any medium. That's quite a large lesion. We're not going to miss that. But when we do this with cone beam, we can make a totally different determination. So let's say that you didn't have cone beam. This patient came to your office. Patient really wants to keep this tooth if it's at all possible. Well, we probably might send this off to the endodontist down the street. It looks like the fill isn't very good. It's quite short. What's the endodontist going to do? Well, the endodontists are embracing cone beam more and more. The endodontist takes a cone beam image of it and charges the patient for the cone beam and for the consultation, and then sends them back to you. And here's the image that they send along with them. So the image on the lower right here, what we see is a 90-degree palatal root. And whoever did the fill here just went straight ahead and really didn't navigate the actual curvature of the root canal, which would be extremely difficult, almost nearly impossible with a file. Cone beam would have allowed them probably not to try this root canal in the beginning, but this certainly cannot be retreated very well. From cone beam, we make a better decision. We decide that this tooth needs to be extracted. Can we get more information? Yes. Look at here, there is no buccal plate in this situation. So when we take this out, It's going to come out quite easily. There's minimal plate on the lingual, and we aren't going to be into the sinus. We see that we're just a bit away from that. But when we take this out, we take this tooth out, if this patient's interested in replacing this tooth and we want to avoid a bridge, we're going to be looking at something where we need to augment the sinus, where we need to do some sinus elevation, some effective bone grafting. So we can inform the patient of that up front. Way better to do that in the start of the treatment and not to send the patient outside only to have them come back just with no treatment. I am getting more and more cases that do get sent out to the endodontist to take out. I think that we understand that implants are coming along, and heroic endodontics is not something that really is worthwhile for the patient or the practitioners for that matter, just because if it's not going to last, then the patients are coming back to us. Let's say we're using that cone beam and the 4 bite wings for part of our regular routine checkups periodically as necessary. Just like we would instead of an FMX. What are we going to see? Well, if we do university-based studies on this, we see an increase anywhere from 28 to 34%, depending upon the studies done. A 28 to 34% increase in diagnosis with cone beam compared to a digital FMX. That's quite a big increase, maybe just an average of, let's say, a third increase in diagnosis. But I contend that it's not just the increase in diagnosis, it's much better decision-making and informing of the patient up front about exactly what's going on. So we get more than just that increase in diagnosis. Again, this lesion right here around this post might be detectable on any kind of imaging, but cone beam is going to allow us to make a totally different decision here. If we scan through this, we're going to look at this in the tangential view. Remember that from Dexter, that's from the buccal to the lingual. Here we're looking at the buccal. These are the buccal roots. We see a close approximation at the tips of these roots right on the sinus. Everything looks good here. We don't see any shadowing or anything that we would have any concern about. If we scan through, though, when we get towards the palatal root, we start to see this shadowing here and this change in the sinus right here. And that certainly has us concerned. But when we look at it from the cross-sectional or side view, we see a totally different image. And here we see we have a perforation. In other words, this is perforated and outside of the root, and this would not be amenable to retreatment. It would need to be extracted. Again, let's take a look at a 3D every day. This is a regular routine scan from just a regular checkup. And as we go through it, we don't see any problems. It's a really nice looking digital image here. And when we start to inspect this, when we get over to looking through the volume kind of systematically, you can look through it however you would normally look through a regular FMX. You want some kind of methodology to your madness there. But when we start to do this in the tangential view, we start to see a shadow of this same tooth number 14. Now, I promise you this isn't a seminar on tooth number 14, although it seems like it. This shadow here looks like it's in the furcation, can't really tell, but we can scan through this volume, right? We're literally looking at hundreds of images, and I'm sorry. And when we look at it from the cross-sectional view, what do we see? We see a very distinct lesion right here that we would not have been able to detect with traditional x-rays. Why couldn't we detect it? Look at the thickness of the buccal plate here. So everything is superimposed when we look at this in 2D. Now we see a lesion. We can get to this patient sooner, help them before they have problems. And just like all treatment and most things in life, when we get to it earlier, we have a better and more predictable outcome. We get a lot more information from cone beam than just that kind of information. We get a lot of information about tooth position. And on the average, from my years of looking at cone beam, the second molars tend to be in the middle of the alveolus. They're right dead center in the middle. By the time you get to the second bicuspid, they tend to be more towards the buccal. And if you see this, we often see cuspids that look like they're completely cantilevered, as well as lower incisors. And so, as you might imagine, or shouldn't be surprised, as a periodontist, I recognize, hey, wait, I'm not surprised this tooth has recession. You're going to see a bunch of images of teeth that you're surprised are even in the mouth. But we can tell a lot about tooth position, which has relevancy. If we take this tooth out here, for example, we realize we're going to have a pretty large defects we're going to need to repair if we're going to put an implant there, for example. We certainly can use this as relative to recession and understanding other clinical problems. And this definitely has relevancy in orthodontics too. If we're going to move teeth around, exactly where is the alveolus? especially in adult orthodontics where the tissues and bone are not nearly as forgiving as they are in kids. Here's one that's not tooth number 14. Tooth number 15 here, we see an apical lesion. When we look at this in cone beam, this patient's in pain. Here's the image. But if we look at this axial view and we zoom in because we're considering endodontic therapy, we realize that we have a 4-canal upper molar. So we know this before we even start. We can decide whether we want to treat that, refer that. The really great thing about cone beam, remember, is that everything is a 1-to-1 ratio. So if, let's say that I'm in here and I can find this canal and I'm doing this root canal, but I can't find the MB2 canal, this one right here, I can measure from here to here. And I've already measured this clinically, and I know that this is 4 millimeters. So I can't find this. I can use this technology to find a canal that's missing. And very useful. Also lets you know whether you have divergence in canals, you have convergence in canals. You can know exactly what you're getting into from an endodontic therapy standpoint before you get started, and you can inform the patient. Here's another case. This happens to be the lower first molar. If we look at this in cross section, again, we can see that we have a 4-canal lower molar, a 3-rooted lower molar. That definitely has implications as far as what we would do. Again, a pretty bombed out dentition, nice looking panoramic x-ray. What do we see here? Let's just take a look at the lower left area, this area right here, this tooth with the impacted horizontal impaction there of the 3rd molar. Well, as far as this tooth, we can see that when we take it out, we have a really excellent buccal plate and lingual plate. This is very amenable to bone fill. We're far away from the inferior alveolar nerve. We know we can bone graft this and have a successful outcome. And if we look at this 3rd molar, we can measure accurately how far we need to cut through this to remove this crown and then advance the roots out. For example, we're taking this out. So we can use this as a tool to section teeth, know how far we need to go down, mark that on our long shank burr at the time of treatment. All kinds of uses for cone beam. Let's take a quick look at endo. Now, endo is got all kinds of capabilities, but I'm just going to give you a quick overview because we can certainly map canals. Let's take a look at what that looks like. Here, we're using endo software. We're going down the canal here. We're marking as we see this in the axial view. Notice we can see it here now in the tangential view. We're going to extend that up to the surface so we know where our access cavity has to be. This is with all 4 canals mapped. Notice we have a working length for each one of those. We can bring in CAD/CAM information, and we can know where those access points are. And we can even mark that purple mark and know what the depth of the pulpal floor is, so we can stay away from that. In difficult cases, we can actually make a guide that allows us to access that with a drill. So if we have a calcification or a difficult to access canal, we can use this as information to do that. Well, what really is a guide? Let's talk about guides for implantology. This was a big thing and still is, and something that I utilize all the time. As a matter of fact, I don't do, having lots of experience with implantology, I really don't do free-handed surgery very rarely. I use guided surgery. It makes it a piece of cake. I do the work in the virtual world where I plan it on the computer, use a guide, that's what we see right here on the right, that transmits this information to the clinical reality, and then I can do the surgery in a very, very short time. So we're taking this virtual imaging and transferring it into the clinical situation. And you would do the same thing if you wanted to access a point on a root canal. So really, the benefits of guided surgery are tremendous, but for me, it saves stomach lining. It makes it a lot less stressful. It makes it much better experience for the patient. I can do a single implant in a really short time, maximum 10 minutes. I do give up some time doing the planning, and not that time is made up for a lot less chair time. Obviously makes it much safer. I can avoid anatomical structures, and I can make it prosthetically driven. These are some of the things that I used to have to think about during traditional free-handed implant surgery. And there's a whole cadre of them, and this probably isn't all of them, but visibility and knowing trajectories and other things is all a big part of that. This is what I need to know when I look at guided surgery. And guided surgery all I really need to do is make sure that the guide fits. That's easy and quick, and that I'm using the right pressure. It just takes a little bit of practice, but guided surgery, you do the work up front, you know what you need. You don't have to have an inventory of implants or anything because you know what size you're going to use before you get started, and makes it an easy experience for the patient, but also from a restorative standpoint, it makes and guarantees that the implant is in an ideal location from a restorative standpoint, not putting it in there and then trying to fix the restorative. We plan the restorative and then put the implant in based on that. Here's a quick picture of guided surgery. Guided surgery, we're putting in a guide here. We're going to put an implant in this area number 9. Now, when I put the guide in this lower right area, the guide and the drill pattern will have a way of creating a stop. This guarantees that the implant goes to the right depth and at the right angulation. So it goes exactly the same place as it is in the software. As I remove the guide after the implant's placed, like I said, maximum time for this would be about 10 minutes. Even in a very angled situation, here's that situation where we're looking at the orientation of the upper and lower teeth. You can see how quite angled it. Implants don't go in straight up and down in that area. There's a big angle to the anterior maxilla. It can be on target. There's all kinds of simple parameters you can learn in implant dentistry as far as how far apart to plan things from natural teeth, from each other, and so forth. But most importantly, we need to keep implants away from the bottom purple line. The bottom purple line is the inferior alveolar canal, and we absolutely want to stay away from that. The little arrow below the implant here shows us that the maximum, or actually, I'm sorry, the minimum distance from the bottom of the implant to the inferior alveolar nerve should be about 2 millimeters. Does anybody know the technical term for hitting that purple or line, that inferior alveolar nerve? I'm listening again, don't hear it. The answer is bad. That's the technical term, bad. Very bad. So easily can be avoided with good planning and technology. No reason to even get near that any longer. This is a simple example of restorative-based implant planning. We brought this image in using CAD/CAM imaging. Ideal cone beam software in your office should be able to merge CAD/CAM if you have it with cone beam, so you can do it in a completely digital workflow. You can bring the tooth in, you can see what the opposing dentition is, you can pick the right size and angulation of the implant, you can create a guide that will put the implant right where it should be from a restorative standpoint, dead center within the tooth, matching up with the opposing dentition. Now, if that doesn't impress you, then I don't have anything for you. How accurate are these? In some systems, these are accurate to being able to place the implant within 1 degree of angulation from the software compared to the clinical situation, and within 0.25 millimeters of the apex. So 25 microns, and obviously very accurate. As you might imagine, if you have these images and you have a way to display them in front of the patients, you're going to have patients that engage these images in ways that you've never seen if you're only working in a 2D environment. 3D environment enriches your experience as a clinician. It changed my practice life. It meant that I understood a lot of things that I couldn't understand. I could do better treatment for the patients. I could do treatment with more information and better decision making, but also I could keep it fresh and new. And that's really been a revolutionary thing for my practice in ways that I never understood. And I have experience both in individual private practice by myself and in group practice both, and it works great in all those settings. So tips for presenting to patients, if you have it, and if you don't, this is what you want to be looking at. Of course, you like things open. Sometimes the processing time to load up a cone beam scan depends on the manufacturer, but anywhere from 2 to 5 minutes to process the image. You want to open up this image, and I like to go to the panoramic view, show them what 2D looks like and its limitations, that we can't see a lot of things, show them the 3D reconstruction in the upper right, move it around in every direction so they can see. It's obviously them, how we can look at this thing in every direction. And then I like to try and address their chief complaint if they have one, or before I go through it systematically. If they need an implant, I like to do what I call virtual surgery, and virtual surgery is really nothing more than showing them how I can drop an implant into a location, make sure that it fits, it's the right size, and that it works. And patients are fascinated by technology, and they're certainly fascinated by looking at these images. Can cone beam get better? Absolutely, and it has gotten substantially better from the time that I first purchased cone beam, but it's not in a way that you would think. Unlike CAD/CAM or optical impressioning of teeth, there hasn't been much change. It's all software driven mostly, and the software is what really drives all of this imaging and how we can move through things, and also how easy or hard it is to use the software. But imaging is usually very good. So I have the same capabilities as I did pretty much when I started, because most of these things are software updates. And what do those updates do? Well, diagnostics have gotten better because we've learned how to subtract out some scatter and other things out of images. Communication between us specialists and other docs and labs has gotten better. We have a digital format to move that around, and everybody's learning how to use that. As you might imagine, better case acceptance continues to improve as this technology improves. And most importantly, we do better for the patient. Nerve mapping, for example, used to be a point by point. We had to go into software, click points, and map. It took us a couple minutes to do that. And if we wanted to show the patient we wasted time with that, we have the ability to do this with artificial intelligence these days. Here's an example of what that looks like. The old way on the left, the new way on the right. Artificial intelligence in some software packages can automatically draw in the inferior alveolar nerve so that we can start presenting to the patient right away. We need to confirm this in the software and make sure that it's right before we move on, but it's pretty good. The same thing happens with being able to optimize the scan and get it in the ideal focus. Artificial intelligence can do that. If you're familiar with Thorac, you used to have to draw on the margins in order to mill a crown. Today, AI can do that. Can also relate the upper and lower jaw. So with lots of types of technology, it keeps getting better and better, easier and easier, more user-friendly. Here's what a inferior alveolar nerve looks like if it's mapped with artificial intelligence. But remember, I showed you that part of the functionality of software is how easy it is to use. Can we get to where we want to go quickly? It's not unlike looking for something on the web. Well-designed websites allow you to move through things with a few clicks and get what you want. Ones that are more cumbersome require lots of manipulation. But in some software, I can map an implant in as easy as 5 clicks. Now I'm going to put an implant where this line is right here on the left. And obviously, we have a couple of roots down here we need to take care of and manage that before we do an implant, clean it out, bone graft it, figure out whether we need to put an implant. We can put an implant at the time, or we need to come back after we've grafted it. But this is what planning an implant can look like in 5 clicks. So if we open up the software, we click on implant, and then we select an implant. Once we've selected that implant, we're going to pick one, obviously, that we know is going to fit easily. We can drag and hold that and drop it right into the scan right where we need to. We can do what I call virtual surgery right in front of the patient. That's transformative. If you're looking at technology for your office, these are the 3 main technology things. Intraoral camera really is a no-brainer. That's something that everybody should have. If lots of benefits there, but the cost isn't really a big factor there. It's an easy thing to incorporate, not very costly. Then if you have to decide between CAD/CAM and cone beam, if you're just getting into digital dentistry, I think that the place to start is with cone beam. And the reason I think that is because of that increase in diagnosis. You're not going to get that with any other technology. You can still do crowns the same way you've been doing them, but cone beam is going to give you the increased case presentation capability, improved diagnosis, and better decision-making. Can it pay for itself in a year? Absolutely. That increase in diagnosis fits right around the model of doing more on less people, and people that are already interested in being in our practice. We're going to get better decision-making, so that's going to save us a lot of time, energy, and going back. We're going to get better patient presentation. We're going to get the vibe of a positive, current, up-to-date office and practice. But most importantly, it's going to change your life in a positive way. It has for mine. I can't imagine practicing without it, for example. And it's going to, at the same time, allow you to potentially do additional treatments that you haven't been doing in the office, like guided surgery. What's the most important thing that you look at first? Cone beam volume. you want to get a volume, in my estimation, that takes a look at all the teeth. That's what we do as dentists. We need to see from tooth to tooth. And if we can't do that, then and we can take a smaller volume. The biggest regret that I hear from people that have already purchased cone beam when I'm doing cone beam education is that after they see all these capabilities, they wish they would have purchased a larger unit because they didn't understand that they were just looking at to look at small areas, which have a smaller volume will have a less cost, but you won't have the same capability. You have to shoot a bunch of images to see all the teeth. So get all the teeth. You want to get image quality for a low exposure. Remember, if you see an image that looks a little bit better, don't be fooled. Oftentimes that means that they've turned the exposure way up higher to get a better image, exposing the patient to a lot more radiation, but really without getting any improved diagnostic capability. It's not something we should be doing. You want to make sure the staff can use it. You want to make sure that it's user-friendly, software-wise. And I think you want to make sure that it can interface with any other technology. You don't want to be stuck with just one manufacturer and have to use their CAD CAM if you want to use future CAD CAM to integrate with this in your digital dentistry adventure. And I think you should use somebody that's been around for a while, of course. So what's your next step knowing all these things? Well, next step is to do what you do with the car, or take it out for a test drive. Get your hands on the software, play with it, use it, ask lots of questions. If you're just getting into the stuff, remember, just do the same thing, get in there and figure out how to do those simple things that I mentioned earlier. Now, back to that quiet revolution that's been going on. Remember, this has been a secret. Manufacturers went after implantology, not understanding what they had in diagnostics. These images actually are not from cone beam. These images are from an industrial magazine that uses this technology and this type of technology for quality control on assembly lines. And they look at all those same things and they realize that, shoot, we can get a lot more information from really using better digital information and 3D reconstructions. And then we can digitize these things and have these for the future, for future comparison, just like we can for patients. So lots of stuff in a short time. This is obviously just an overview, not training. Training takes a little bit longer to give some of these things a little bit better chance and explain them more thoroughly so you can completely understand it, but at least you know what the possibilities are now. Now, I'm going to go to questions and answers, but I'm going to start out with a few that I get all the time with cone beam. And isn't cone beam primarily for implantology? I hope I beat that one up. I think I've worked that one over. We can skip that one. What about liability? A lot of people were concerned about getting larger volumes because, boy, what about all these other things that come up on cone beam in areas that I'm not familiar with, like the sinus? The leading people in defending dentists in malpractice cases, one, Art Curley in San Francisco, has written a position paper where he indicates that there isn't any increased liability for dentists using these images, only in areas that we have absolute training for. And training would be dental school, not continuing education. And so we need to be responsible for the teeth, the upper and lower jaw, like we would be in anything. We're not going to miss it. Why? Because we have a lot better imaging from it. So we're not going to do that. What should you consider with CBCT? Those are laid out here. Remember, we talked about field of view, quality image again without overexposure. Workflow, we mentioned that. The integration, we talked about that. And of course, you need support. And then this last one is one that I get a lot over the last several years, more recently. Besides maybe a bigger field of view, what's the difference between a premium brand, a high-end brand machine, and an entry price machine? And the answer really is, other than some of the premium ones have a much larger view that look at the entire skull, there isn't a difference. A lot of the entry-level machines now have artificial intelligence. They have the same implant software capabilities, and they can integrate with any kind of CAD CAM or optical impressioning. So that is my presentation, and I'm happy to entertain any other questions that you might have. That's the Sandia Mountains, by the way. That's New Mexico. I live at the base of this mountain. It's about 5,600 feet, and kind of cold this time of year, but beautiful place. Questions?
Hi, everyone. My name is Jennifer Brown, and I'm working with Dr. Brandis tonight to answer some of your questions, make sure that they're in front of him. Dr. Brandis, just so I make sure that I say this, thank you for giving such a thorough presentation. You have answered a great deal of the questions that have come through, but I have one or two that I think we may still have time for. And please, everybody feel free to type your questions into that chat. We'll get them right to Dr. Brandis here. One of the questions is, from Dr. Karori, where can we find a training course in CBCT? So great that we had this webinar, but where could we find more education?
I think the best place to go is usually through a manufacturer. If you have a cone beam already, if you're looking at that, that should be part of what you look at when you're considering a cone beam, is what kind of educational program they have. Now, the learning curve for this is quick. You can get into it pretty quick. But as you can see, there's a lot to know in order to be able to drive it. You don't want to have a really nice car and never be able to shift it out of first gear. And I see that happen a lot with cone beam because they got into it for one use and then really missed a lot of the other capabilities because nobody explained it to them. So.
Wonderful. Let me see. We have another question from a Dr. Cormack, who's asking when it's appropriate to take a CBT, CT, specifically on children.
Yeah, I'm glad you asked that question. That's something that I should have covered. The question about kids, we always have to be reluctant for exposure to kids, just like we would with any other imaging. And so I think we need to stay away from that, have specific needs, and take isolated periapicals when necessary. So when I was talking about the cone beam every day, I certainly was referring to adult patients and not to kids, because I think that although the exposure of a scan can be as low as 70 microsieverts, it's a very low dosage. For kids, I still think we need to be sensitive to that, and it's something that we really should be reluctant to do. Only use it when we really have something special needs or something we really need to check. So thanks for that question.
Terrific. Let's see. They are coming in fast and furious. Here is one, I believe, from James, and he's asking if there are any other types of software other than the one that I guess would get included in your purchase from a manufacturer that you could use with your machine. It looks like there are a lot of accessory questions that way, monitors, computers, and software in particular.
Yeah, a lot of this stuff, a lot of cone beam software can be obtained as outside that can use any kind of cone beam scan and use any kind of optical impression CAD/CAM imaging. The one that I use is called CCAT. It's no longer a proprietary thing, and it can be purchased for any one of these formats, and you can use that. I was showing software pictures from several different formats of scanners here tonight, by the way, not just one. And I think that, yeah, you can find that on the regular market. That's SICAT. I think you want to be able to do these things in your office. I don't think you really want to go to third party if you have a choice in order to do this. You certainly can transmit this information to an outside party if you want them to do some planning and placement and other things implant-wise, if that works with your workflow. In this digital world, we have all kinds of possibilities. We can pick and choose and do what we feel comfortable with to do the treatment that we feel comfortable with. And that's what keeps it interesting. Nobody wants to do the same treatment 5 years from now that we're doing today. And cone beam and using this technology is part of that. Now, when do you take a cone beam scan, just on a patient? Well, I like cone beam plus 4 bite wings and any isolated PA I need of an area that I think there might be caries. Because cone beam isn't quite to the level that it can diagnose caries, I do believe it's going to get there. The image quality is going to get there. We're pretty close to that. But I do it whenever you'd normally do an FMX. What does that mean? We did an FMX on every new patient, even if they didn't have any pathology as a baseline. And that's a really important thing. And obviously, we're getting 3D volume dimensional information that we can look back on if we need to. And then how often do I do it? As often as you would repeat an FMX. And that is in people with a lot of disease, that would be, much more often. If people didn't have a lot of disease, that might be every 5 years. But same kind of information. If you just take out FMX and put in cone beam that's what fits with the philosophy. But if you see we do that, then we're going to be using the machine all the time. And that's the way that you make this effective. You don't pick and choose. You get it part of your regular workflow and use it every day. And that's the term 3D every day.
Wonderful. I have one or two more questions coming in. And then if there are additional questions at the end of the webinar, we'll make sure that we answer everybody in an email afterwards. Something's coming up in terms of when you're speaking to the patient about a 3D image, how does, and you did address this, how does that conversation go? But in terms of what would be billed to a patient for a 3D image, perhaps compared to what the regular digital x-rays would be, is there any difference that way?
Well, this is a question. Thanks for that question. That's a really excellent question. And I'm just going to tell you what I do. And can you bill third party and get paid for cone beam? Sometimes. The answer is not that often. Can you bill medical insurance and get reimbursement? Hey, there's people that have done it, but I like to do it easy. And I benefit so much in the practice from having this that I'm happy to charge a pan fee for a cone beam scan. In companies like Delta, where if you have to have an approved fee schedule, every time that I can elevate my fee, I elevated my pan fee, so I can be compensated for that. And then I just bill an FMX for the scan plus the bite wings. Basically, pan plus bite wings. You get a reconstructed pan, you get four bite wings, and I charge for an FMX. So I can get reimbursed for that. Obviously, I try and elevate those fees. But the diagnostic capabilities and the other things I get from it, I'm happy to do that. So, and with some software, when they come back in, you have the ability to limit your scan down just to an area that you're interested in, or get the from third molar to third molar. There's some technology differences from software there too. But that's a good question. We need to get paid for it, and you can. And so just gradually elevate your FMX fee a little bit, gradually elevate your pan fee a little bit, and you won't ever be looking back. Trust me, if you start using this all the time, you're not going to look back about whether there's a decent return on investment. Of course, you have to use it to get it to pay for itself. And and by the way, we're not doing this obviously because we have it. We're doing it because we can get so much more information with that.
Wonderful. I am getting lots of comments, so thank yous and excellent presentations. And Dr. Brandis, I think that we were at time. So I am going to turn it back over to you. And again, thank you so much for letting me participate.
Yeah, you're welcome. You have my respect for staying up in the evening and working on your knowledge. I have had a long career in dentistry. This has made more difference in my clinical life than anything that I've done by far. I got into this for implantology and saw all these other things when I taught general dentists. This technology stuff that really changed my understanding of dentistry, but also has kept it interesting. You have my respect for dedicating some time to learning. I know a lot of places it's required, but it's really what keeps our profession on top and allows us to deserve the respect that we have, and that's staying current and staying up on things. From New Mexico, have a good night.